Good morning, good afternoon. I'm Jennifer Stransko, Physician Engagement Associate of MAVEN Project, and I welcome you to today's session on diagnosis and management of eczema, a session from the partnership with MAVEN Project and Direct Relief. It is my pleasure today to introduce today's speaker, Dr. Ginette Okoye, is Professor and Chair of Dermatology at Howard University College of Medicine. We are very lucky to have her today as a speaker. Dr. Okoye, I will have you share your slides and feel free to begin.
All right, thank you, Jennifer. Thank you all for having me back. Hopefully you can see my slides already. We're going to talk about eczema today, and you're going to see lots of pictures, and then we'll do a couple of cases as a way to talk about how to manage patients with mild disease and then how to manage patients with more severe disease. So these are my disclosures, and you already heard about the CME credits and the things that you have to do to obtain it. All right, let's dive in. And I always like to start with a definition. What is eczema? That word is used a lot, and it's used by different people in different settings. It's basically a broad term that describes a group of conditions that cause itchy, dry, inflamed skin. And so there are different types of eczemas, and you'll also hear people say dermatitis. So eczema and dermatitis are synonyms. And today we're going to talk about atopic dermatitis, the most common form of eczema. But there are other types, allergic contact, seborrheic dermatitis, all other types. But we're going to talk about atopic dermatitis today. So you'll hear me say eczema, you'll hear me say atopic dermatitis, you'll hear me say dermatitis, all mean the same thing for the purpose of today. Now, with atopic dermatitis, we don't know exactly the cause, but it's probably multifactorial. So you probably start with a genetic predisposition towards getting atopic dermatitis, and then environmental factors like allergens in your environment can bring this out. And then people with atopic dermatitis have inherent differences in their skin barrier function. And we'll talk a lot about that in a few slides, because that is the mainstay of treatment for eczema, or any type of eczema, is to shore up that skin barrier. That's the best way to prevent eczema flares. And so we'll get into that in a few slides. So these are the essential features of eczema or atopic dermatitis. If these features are not there, it's probably not atopic dermatitis. And I'm sharing this slide specifically because a lot of other diseases in dermatology are misdiagnosed as eczema. Types of skin lymphoma, for example, leprosy. Like, there are a lot of skin diseases that we see patients years into their treatment for quote unquote eczema. So here are some findings that have to be there, or you're looking at something else. Itching. If someone with atopic dermatitis is not itchy, it's not atopic dermatitis. It is that simple. This is called the itch that rashes. The itch almost comes first in many cases, and then the patients develop the lesions. So I can't say this enough. If you have somebody with quote unquote eczema and they are not itchy, they don't have eczema. It's something else. They need a biopsy. The other essential feature is red or erythematous, or in people with brown skin, it may not be red. It may just be hypopigmented or hyperpigmented, dry, scaly lesions anywhere on the skin. And something pretty specific for atopic dermatitis is that it comes and goes. Even when people are under really good control, something will trigger a flare, and it'll just relapse and remit through most of their life. The other thing about atopic dermatitis that's important to know is there are very typical age-specific patterns of where the lesions tend to occur on the body. I'm sorry, my slides are going on their own, so forgive me if I'm going back and forth sometimes. And then the other thing, another super essential feature, is that in general, people with atopic dermatitis have a personal or family history of what we call atopy. So what's atopy? Atopy is the genetic tendency to develop allergic diseases like atopic dermatitis, asthma, and hay fever. And there's something we call the atopic march, where basically the first thing you get if you have this tendency is eczema when you're a baby. Then in childhood, you start developing asthma. And then in late childhood and adulthood, you develop hay fever or allergic rhinitis. And so you see here on this slide, it says that 50% of children with atopic dermatitis will go on to develop asthma. And then over 50% of those kids will go on to develop hay fever. And so one of the things that's coming to light is that if we treat eczema properly early in life, we might actually prevent this atopic march. So can you imagine if we can prevent some cases of asthma from developing? Think about the disruption to patients' lives and their schooling and stuff that they experience when they have asthma. So eczema is not something to necessarily just put to the side and say, okay, we have bigger fish to fry with this kid. This is a big deal. It can absolutely change the course of their lives if you treat the eczema aggressively upfront. It could even decrease the risk of developing food allergies because some of the food allergens get in through the skin and sensitize patients that way. So let's talk about these age-specific patterns. So you see here in babies, eczema tends to occur on the cheeks, the extensor parts of the forearms, and the trunk. In children, it tends to go to the flexor part of the forearms and the legs. So that's like a typical, when we think of eczema, we think of the flexural areas, but know that in babies, it's the opposite. And in adults, again, it's the flexural areas like the neck, the antecubital fossa, the popliteal fossa, but also the hands and feet. So hand and foot eczema tends to develop later in life. So here are some photos. Here's a baby with that classic cheek involvement. Here's a close-up of a baby, and you can see this is a really nice example of dermatitis. It's red, it's scaly, and clearly this baby looks really unhappy because it's pretty itchy. Here is another infant where the extensor extremities are involved. And I share this photo because this patient has pigmented skin or skin of color. And you can see that on the trunk, there are these fine papules, very fine little bumps. That's called follicular eczema, and that is much more common in people with skin of color. The other thing that's more common in skin of color is hyperpigmentation. You can see how red this baby's face was. Well, this baby is just as inflamed, but it's not red because it's harder to perceive that red through the pigment. The other thing that's more common in skin of color with eczema is this, what we call lichenification. It's thickening of the skin where you get this accentuation of the skin lines here. We're not sure why in skin of color that's more likely to happen, but it could be because there are some differences in African Americans specifically, where the stratum corneum has more cell layers, and so perhaps that just gets thicker easier. We're not sure. Here's a nice sort of classic flexural involvement in a child with eczema. And then later in childhood, well, in adolescence and adulthood, then you tend to see hand and foot eczema, what we call dyshydrotic eczema, where people get these very, very itchy bumps that look almost like tapioca pearls. There's a nice close-up here. They're incredibly itchy. And hand and foot eczema is difficult to treat, but we'll talk about that. Here's a patient with pigmented skin with hand eczema. Again, that redness is not apparent, but it is still actively inflamed acute eczema. I share this photo again because it's like this nice demonstration of what dermatitis means. You got your redness, your skinniness, and you can see it's itchy because they have these erosions here from scratching. And then this patient also has what looks like some secondary infection where they develop pustules, probably from staph infection there. As I mentioned a couple slides ago with the African-American baby who had those fine papules on the trunk, this is a close-up of that follicular eczema or follicular atopic dermatitis. Super itchy, same acuity, it can be really very subtle. And just to drive this point home, I really can't say it enough. Redness is not a great measure of severity of eczema in brown skin. If we see this child on the left, it looks inflamed. This child needs a good topical steroid here. But this child, it could be mistaken for post-inflammatory hyperpigmentation. You might think, well, this is a child who had an eczema flare and now they're better and the hyperpigmentation has to resolve. No, this child is just as inflamed as this one and needs vigorous therapy. And you can see all over his trunk. This is normal skin for this child. It's upper arm here. This is normal skin. All of these hyperpigmented areas are involved with the eczema. Just want to share a nice close-up here of lichenification, that thickening of the skin with accentuation of the skin lines, very common in eczema, and it's basically caused by scratching. So eczema is incredibly itchy. Patients scratch all the time. It almost becomes like a habit, and the skin that they're scratching thickens to protect itself in a way. That's the way I describe it to patients. The skin thickens to almost protect the structures underneath it. And that thickened skin, the nerve endings in that thickened skin are not normal. And so that skin is even more itchy. And so they get into this vicious cycle. So once you see lichenification, you know you have to deal with not just the rash on the skin, you have to deal with the fact that they are incredibly itchy, or you're not going to get them out of the cycle. Here's another example of lichenification. I'm showing you lots of pictures of this because it's such a good clue to the severity of the disease. They could have one patch of eczema and it's lichenified. You know that they are going after it. They're scratching this thing all day, all night, and you got to help them. This patient is a nice example of when patients scratch, they can have these little erosions here. And of course, that's a great entry point for bacteria to cause infection. This is a good reminder that atopic dermatitis can occur in pregnancy. It can worsen. People who have atopic dermatitis, their atopic dermatitis can worsen in pregnancy. Or there are people who have mild have no atopic dermatitis and then can just pop up with eczema during pregnancy as well. So, just something to keep in mind. And I just wanted to show it to you in two different skin types here. Okay, so let's jump into how you manage atopic dermatitis, and we'll use a couple of case studies to guide the discussion. So this is a 6-year-old boy. He has this asymptomatic, mildly scaly, hypopigmented patch on the face. It's been there for a few months, and his mom says that it seems to worsen over the summer. And mom also complains that his skin is always dry. Doesn't matter how much lotion she puts on him, he's just always dry and scaly. His medical history is notable for seasonal allergies, and he has a sister who has asthma. So what are the clues that we got from this slide? Well, first of all, this is pityriasis alba, which is essentially mild eczema. Okay, so we're going to use this as a way to talk about mild eczema. So what if you saw this patient and you're saying, well, what is this vitiligo, or is this something else? Maybe you're worried this might be seborrheic dermatitis. How do you know this might be eczema? Well, the lesions are dry and scaly. We talked about the fact that that's a pretty classic finding in eczema. But the clue here is that he has a personal history of atopy. He has seasonal allergies. He has a family history of atopy. His sister has asthma. So this child is at risk for eczema. It's probably more likely eczema than something that's more rare like vitiligo. Other clues you can look for if you're wondering if what you're looking at is atopic dermatitis versus something else. You can look at the patient's palms. They can develop something called hyperlinear palms. If you look at your own palms right now, you should have a standard number of lines. But if you have a lot of lines, like the picture below, you probably have atopy. It's a pretty good clue. Another good clue is ichthyosis of the shins. So that's dry, scaly skin on the shins. These are people who, and I'm sure there's some of you in the room, it's that common, who they're like always moisturizing their legs, but even when they do that, they could still see these like lines that make it look like fish scales on the front of the anterior lower leg. That's another clue that you might have atopy. Just another close-up of hyperlinear palms. It's such a nice clue. And if you start looking at people's palms, you'll see it's relatively common because atopy is relatively common. Another clue that someone might have atopy is, especially in infants, in children, young children, is this lip lickers dermatitis, where they get this rash around the mouth just from chronic licking of their lips. And it's because their lips are dermatitic. Their lips are itchy and dry. And so they're licking it to try to moisturize it. And then that's causing irritation and they get into this vicious cycle. And here's another really great clue to atopy. These are called Denny Morgan lines. You see these lines here under the eyelids, usually two lines. That's a really great clue to atopy. And then something called allergic shiners, meaning it looks like this kid almost has a black eye on both sides. And it's from, atopic dermatitis in that area, but mostly it's from this. They're so itchy, and sometimes they have just allergies, conjunctival allergies as well. And so they're chronically rubbing this area, and that rubbing causes mild lichenification around the eyes and leads to these extra folds. Here's a patient with brown skin with the same thing. You can see these Benny Morgan lines right here, and then the general kind of redness around the eyes, looking like they might have a black eye. Another thing that's a nice clue that's in this photo is the central face of this child is relatively pale compared to the rest of his skin. That's called central facial pallor. And that's another clue that you're looking at an atopic person who might have eczema, allergies, food allergies, and asthma. And of course, pityriasis alba, the same as the case we're talking about. That's another clue. Eczema. And then finally, keratosis pilaris. So I'm sure you've met people who have these spiny papules on the upper arm. Some people have it on the outer thighs as well. It's not diagnostic of eczema, but it tends to occur in people who have atopy. So those are your clues. Here's a close-up of keratosis pilaris. How do we manage someone like this kid who has relatively mild disease? Well, the first thing you want to do is to shore up that skin barrier. And this is the standard skincare treatment for anybody with eczema, mild, severe. We could be doing systemic medications. We still need them to start protecting their skin barrier to decrease the risk of future flares. And just to review the barrier of the skin. So basically, when I think of the epidermis of the skin, I think of it as like a brick wall, where the bricks are the skin cells, the keratinocytes, and the mortar between the bricks are these ceramides and other lipids that exist in the skin. And so in people with eczema, that barrier is dysfunctional. And for some of those patients, the ceramides, some of those lipids are not there. And so it's really easy for allergens, bacteria, etc., to make its way through the epidermis. And it's really easy to allow water out of the skin. So all of that contributes to dry skin and to inflammation. The most important thing that disrupts the epidermal barrier, in addition to eczema, is soap. So typical soaps are alkaline, and they just strip those oils right from between those skin cells. Hot water, very hot water, does the same thing. Whereas moisturizers help to either build up the barrier by literally contributing lipids to that mortar, and that's done by ceramide-containing moisturizers, or there are moisturizers that we call occlusive, where they're basically forming a layer, a fat layer above the epidermis to prevent water from coming out, what we call transepidermal water loss. And so I recommend very specific soaps for atopic dermatitis. This is, I've tried to put many different options here. The key is the soap has to be what we call a syndet, a synthetic detergent. And these companies tend to create syndets that are not drying and won't strip the barrier. I love petroleum jelly as an occlusive moisturizer. Some people are really worried because it's petrochemical based, but it's such a big molecule that as far as we know, this is not penetrating the skin at all. What it is just creating a layer over the skin. And if you apply it when the skin is damp, it basically locks in water close to the skin and hydrates the epidermis and prevents water from leaving the epidermis. There's some other brands that I included here. The CeraVe brand is one of the few that has ceramides in it. Do those ceramides truly make their way into the epidermis? We're not sure, but it's still a pretty good moisturizer. And any of the creams listed here can be mixed with petroleum jelly, just right in the patient's hand, and they'll get double properties. They'll get the occlusive properties of the petroleum jelly, and they'll get the other properties of the other creams, which we'll talk about in a second. So this is really, really important. Dry skin is the enemy of eczema. Dry skin will flare a patient with eczema. So if you do nothing else but change their soap, you would already have made a difference. If you do nothing else but encourage them to use moisturizers, which many, especially children, don't want to do, you would have made a difference. I'm not trying to throw shade on any particular brand, but I've got to tell you, Ivory soap, Irish Spring soap, they are true soaps, meaning they are as alkaline as possible. Of course, they clean really well, and you smell really good afterwards, but they just take all your oils with them. And so if you don't have eczema, feel free to use your Ivory. But if somebody has eczema and they're using Ivory soap, that is why they have eczema. Please stop it. Let's delve a little bit into moisturizers. I'm a dermatologist. I think about products all the time, and I love thinking about products. And I wanted to share this with you because I think if you know some of the science behind it, you'll be able to pick your own moisturizers really well and help your patients. So it's not so much about the brand name, but about the contents of the moisturizer. So we have 3 different types of moisturizers. We have lotions, which are watery. They usually come in a pump. Right, so you press the pump and this kind of very liquidy lotion comes out. They have more water than oil. They're thin, they spread pretty easily, but if someone has eczema, a lotion is probably not thick enough. They're not going to get enough protection from the transepidermal water loss that's inherent to their eczema. So lotions, I probably wouldn't use them. Creams are about 50% oil, 50% water. They're thicker than lotions, but not as thick and greasy as an ointment, and they absorb into the skin pretty quickly. And so lots of people really like creams more than ointments, which are more greasy. And so ointments are the next category, and ointments and oils, I put them in the same category. They are the occlusive moisturizers that are mostly oil. Like petroleum jelly has no water at all. It's 100% petrolatum. They absolutely decrease water loss from the skin, but they're very thick. They don't spread as easily, and some people just don't like how they feel. And so examples other than petrolatum include mineral oil, cocoa butter, shea butter, olive oil. People who like to use natural products might gravitate more towards the ointments and the oils, and they are fine. If a parent, for example, tells you, I'm using cocoa butter on my kid for their eczema, that's okay. That's great. Most cocoa butters are actually pretty occlusive and are good. And then a fourth kind of Derm 201 category of moisturizers is called a humectant. And so humectants attract water from the atmosphere and from deeper in the skin into the epidermis. And what you want to do is combine, ideally, a humectant and an occlusive moisturizer. So the humectant will pull water from the dermis into the epidermis, and then your occlusive moisturizer keeps it there. If you use only a humectant, it's going to pull water into the epidermis, and then that water is going to go out through the defective barrier. So you have to combine those two, and that's why CeraVe and Cetaphil and Gold Bond, those creams, if you combine them with petroleum jelly, the patient is going to get the benefit of the humectants in those creams and the occlusive of the petroleum jelly. Some examples of humectants include glycerin, honey, lactic acid. Now that you've seen this slide and you'll have it in your handout, go look at your moisturizer bottles at home and see what you got there. More than likely, your first ingredient is going to be water, in which case you probably have a lotion. But in those first 4 or 5 ingredients, you want to see one of these occlusive moisturizers and a humectant. Otherwise, you need another one. Okay. Another way to prevent flares of eczema is to manage the patient's environment a little bit better. So we talked about water loss through the skin. If they are in a very dry environment, a low humidity environment, they're going to continue to lose water more readily. So we recommend that they get humidifiers in the bedroom, or at least the room where they spend the most time. And in the winter, when the ambient humidity is lower, that your moisturization has to be even more vigilant, twice a day, more occlusives, that sort of thing. For people who can't necessarily afford a humidifier, just having a big pot or a bucket of water in the room is helpful because that water evaporates into the room and adds humidity to the room over time. Or if especially in smaller spaces, if someone's taking a shower and they're using hot water and there's steam, we say just open the door, let that steam come out into the apartment or into the home to, increase the humidity of the house. Another way to prevent eczema flares is to avoid triggers. And those triggers are different for everybody, but many people with eczema are triggered by fragrance. And some people with eczema are triggered by wool. So avoiding wool products and using fragrance-free products as far as possible is what I would recommend. And just FYI, Aquaphor, the brand, which is sort of a competitor, I guess, to petroleum jelly because it has that nice occlusive property, but it's not 100% petrolatum. It's, I think, like 60 or 70%. It has some other stuff in it that's supposed to make it, nicer, more elegant. But some Aquaphor products contain lanolin, which is a wax ester of wool. So if your patient is sensitive to wool and they're using Aquaphor, they might be in this vicious cycle and they're just not getting better. So keep that in mind for patients who are using Aquaphor and not improving. Okay, so what would I do for this child with mild eczema? I would change to a gentle soap, like we talked about. We'll talk about moisturization with the parents. And then I think we would move to topical anti-inflammatory therapy. And you can use either a low potency topical steroid, like a hydrocortisone 2.5% in this case, or in this case, I would preferentially choose a topical calcineurin inhibitor, like pimecrolimus cream or tacrolimus ointment. So we'll talk about those in a second. And with either the topical calcineurin inhibitor or the steroid, you would apply it twice a day for 2 weeks. And, eczema waxes and wanes. It may happen again. You just repeat that course as needed. Something important to remember to tell patients about pityriasis alba is it will take a few weeks for the skin color to normalize. So the scaliness should go away quickly, but don't be surprised if it takes a while for the color to come back. And it does look worse in the summer because the surrounding skin tans in the summer, but the pityriasis alba skin does not. And so that's why usually we see patients in the summer for this because that's when their parents realize that it's there. Let's talk about the topical calcineurin inhibitors. That's what I would have chosen preferentially for this child, also called TCIs. They're FDA approved for the treatment of atopic dermatitis, but we use them in other things. We use them in vitiligo, psoriasis, etc. There are 2 of them, pimecrolimus 1% cream and tacrolimus ointment. And there are 2 versions of tacrolimus, a 0.1% and a 0.03%. The 0.03% is approved for children. 0.1 is approved for adults. Now, we have a relatively hard time getting these covered. We get them covered, but we almost always need a prior authorization. And so I just wanted to help you get your prior authorization done easily. You have to address the things that are in bold here in this slide. So they are approved as second-line therapy. So you have to have tried a topical steroid, or you have to inform them that the topical steroid is not appropriate in this case. It is the face of a child. It is an eyelid. It is on the genitals. These are areas that you can argue it isn't safe to use a topical steroid. And usually that is enough for us to get it covered. And I would just put this in your note so that when you send the note over with the prior authorization, they can see what they need to see to give you a yes. They are not approved in children under 2, so you probably won't get it covered for children, for infants. Just use a topical steroid in an infant. That would be fine too. What I like about the TCIs is they're really useful for maintenance therapy. If a patient is in a flare of their eczema and they're super itchy, that's not what I would start with. I would actually start with a steroid, get them under control for about 2 weeks, and then stop the steroid and give them the topical calcineurin inhibitor to use twice daily to keep things away. But In people who are pretty well controlled, if at the very first sign of a flare, they start using their TCI twice a day, sometimes it can actually, bring the flare back under control. But once it's fully flared, it's not as helpful. And just an important note, both of them can cause a warm sensation, or some people will interpret that as a burning sensation with the first few applications. So just warn people about that so they don't get worried. It tends to get better with time. Tacrolimus is an ointment, so it's greasy. But remember, we talked about the fact that people with eczema, an occlusive moisturizer is good. So the carrier vehicle of the tacrolimus is petrolatum. And so I kind of prefer the tacrolimus, but some people don't like the greasiness. Pimecrolimus is a cream, so that rubs in really nicely. Most people prefer that, especially on the face. But honestly, we just get whichever one is on the formulary, and it's usually tacrolimus, not pimecrolimus. They do come with a black box warning that I am not at all worried about, but I do tell patients and I tell parents, especially because when they go to the pharmacy and they get this long handout, they're going to get worried. So this is the black box warning about lymphoma and topical calcineurin inhibitors, but there's been a long ongoing study since I was in residency. So 20 years of data have not shown any cancer risk greater than seen in age-matched populations. Plus, tacrolimus and pimecrolimus, the actual molecule is so huge that there is minimal absorption into circulation. However, if you're in a big eczema flare and you have some erosions and stuff in the skin, then of course you're going to get a little bit more absorption that way. But I'm not worried about this, but I would just tell people about this ahead of time. Another newer non-steroid anti-inflammatory option is crisaborole 2% ointment. I've never gotten this covered, so I tend not to use it. But I've heard my colleagues say that patients complain that it burns or stings on application, and it is approved for use in people 2 years and older. Okay, so that's our mild patient. Let's talk about a patient with more severe disease. This is a 10-year-old girl. She has widespread eczema on the face, trunk, and extremities. She's had eczema since she was an infant, and it seems to be worsening according to her parents. She's extremely itchy. It keeps her awake at night and therefore keeps them awake at night when she's running in and out of their room all night. She's sleepy during the day, so she can't concentrate at school, and she's not doing well at school at all. She's been given hydrocortisone 2.5% cream, and that's what she's been using for years, and it doesn't seem to be helping. So how would we treat this child who has what I would say is moderate to severe eczema? Always, we have to talk about eczema skincare, the gentle soaps, the moisturization, the humidifier in the room, all of those things we just talked about. I certainly want to get her on a topical steroid, but hydrocortisone 2.5% is not going to do it. That is the only time I would use hydrocortisone is on the face for a couple of weeks in mild disease. But these children need at least triamcinolone, so at least a medium potency strength steroid. The other thing I'd like to do with her is antibacterial therapy, like a bleach bath. And the clue to that, you'll see some pictures later on, but you see how scaly she is, especially around the orifices. I don't know, I tend to find that people who have that type of eczema maybe have a little bit more Staph aureus colonization. And we know that Staph aureus colonization worsens eczema. So we would do bleach baths to decrease the staph burden on her skin. We'll talk about the details of that. And then they talked about how itchy she was when they came into the visit. She's super itchy. She can't sleep. We have to figure out the itch piece, or the eczema will not get better, and her quality of life will continue to suffer. And if none of these things work well enough, then we're going to put her on systemic treatment, whether it's phototherapy or a biologic like dupilumab or a JAK inhibitor. And we'll talk about some of these as we go along. Let's talk first about this antibacterial therapy. So people with eczema, not just because of the barrier dysfunction that they have, there are some differences in their local immune system in the skin that makes them more susceptible to colonization by staph and by yeast like Malassezia. And those colonizations, even though they're not infection, will drive disease activity. So we have to, if we find those, if we see that, try to decrease the burden of those bugs on the skin. And then, of course, there are patients who develop secondary infection. They're scratching, the lesions are open, and then if that staph is hanging out on the skin anyway, it could certainly get, entry into the dermis and cause infection. I tend not to use antibiotics unless they have evidence of infection, like impetigo, like honey-colored crusting. So like this child has pretty severe eczema around the mouth here, and you can see it's eroded and the crust is yellow. That's a child I would probably do some mupirocin or systemic antibiotics like cephalexin. But my favorite, my go-to is a dilute bleach bath. And the way I explain this to patients and to parents is think of it as being in a swimming pool. It's the same concept as a swimming pool, which helps people. Their first initial reaction when I say bleach bath is like, what? Is that safe? Especially, is it safe for the genitals, for them to sit in bleach water? Like, yep, it's just like being in a pool. And this is the recipe. So a quarter cup of bleach to a half a tub if it's a smaller person, or a half cup of bleach to a full tub. If for any reason the patient experiences a stinging sensation, which doesn't happen often, you can either decrease the amount of bleach or just add a half a cup of baking soda just to help with the pH, and that tends to help. And we do this 2 or 3 times a week. I specifically said here regular strength bleach. So, like the dollar store bleach, like the old school bleach. Now we have all these fancy bleaches that are double strength and triple strength. Well, if you have a double strength, then you want to use half of this recommendation. So that's why I tell patients, go look for just regular old bleach, and then you can use this recipe. What we really like to do after the bleach bath, the person soaks for 5 or 10 minutes in their bleach bath, and then they get out. You barely dry them. So you leave the skin a little damp, and then you apply the topical steroid. So the topical steroid is now holding in that hydration, especially if it's an ointment, it'll hold in that hydration in the epidermis. And then you put the pajamas on, whether it's an adult or a child, you cover the whole body in clothing, and it really helps to help to hydrate the skin and make sure that the topical steroid penetrates a little bit better. And that's what we call a soak and smear. So you soak in water with plus or minus bleach, and you come out and you smear them with their topical steroid. And I'll also take this time to make this point as well. I think there's sometimes some confusion with children, especially who have eczema, and sometimes the recommendation is that they shouldn't take baths or showers as often, because I think we all sort of figured out that baths sometimes made them worse, but it's because of the soap. So if they're using the wrong soap every day, their eczema will get worse. But if they're using the correct soaps, a bath or a shower every day is helpful because it helps to decrease that staph and malassezia burden on the skin. So we do recommend at least daily baths or showers for people with eczema. In terms of the antibiotics, I mentioned I would use mupirocin ointment if I think they are actually impetiginized twice a day for a couple of weeks. And I would avoid neosporin and bacitracin, which sometimes the patients are trying on their own over the counter. These patients are at high risk for developing a contact dermatitis to neosporin and bacitracin. So I would just, the skin is open, like those allergens are going to be easily getting in and sensitizing them. So I would not use that. And then I don't usually use systemic antibiotics, but cephalosporins or doxycycline if needed. That's our antibacterial therapy. The next therapy is topical steroids. I want you to leave this talk not afraid of topical steroids. We did a lecture, I think, a few months ago on topical steroids and how to use them safely and how to sort of be a master at them. So please feel free to go back to that. I really got into the details. But in general, I think it's better to use a strong topical steroid, even in children, twice a day for 2 weeks. Knock the inflammation out. That's way better than using a weak topical steroid, and then you have to use it for much, much longer. So don't be afraid to increase the potency so that you could use it for a shorter amount of time. The vehicle of the steroid is really important. The ointment vehicle is stronger. First of all, you're going to get more potency. It's going to work better than a cream, and it's going to be occlusive. So that barrier issue that your patient with eczema has, your ointment is going to help with that. Additionally, creams tend to burn on application when patients have active eczema because the creams have things that the ointments don't have. They have stabilizers and um, like quaternarium and all of these things like preservatives, etc., that can cause burning, and the ointments simply don't have any of those. And then for people with widespread disease, I love giving them a big 1 pound jar. So you can literally write on the prescription 1 pound jar or 454 grams, which is harder to remember. This is what it looks like. And the patient gets this. So it's enough for them to apply to multiple parts of the body. Just resist the urge to give them a 30-gram tube that will be done in 2 days. Give them enough. Don't be afraid of it. Remember, we talked a little bit about the soak and smear. So apply the steroid to damp skin at least once a day. That will really amp up the efficacy. And then for more severe areas, areas where the skin is pretty thickened, and certainly in adults, sometimes I'll go really strong and use a class 1 steroid like clobetasol or halobetazole twice a day, 2 weeks maximum. And then we can go back to a weaker steroid because sometimes they just need that extra boost in efficacy before using the milder one. But of course, these stronger steroids we would never use on the face or in any body folds because once there's skin on skin contact, those steroids get much, much stronger. That occlusion of skin on skin makes it even stronger. So don't use them in the body folds, like under the breast or under the armpits or in the groin. This is a nice chart that I love of the topical steroids of different classes. So class 7 is the mildest, class 1 is the strongest. So your over-the-counter hydrocortisone is a class 7. I would never use that in eczema. It's just not enough. I would stick with maybe triamcinolone ointment. I think is a great place to start. If you need something a little stronger, fluocinolone ointment is a great option, and it's usually well covered by insurance. And then here are my friends clobetasol and halobetazole that I sometimes have to pull out of my pocket to use when I need something much stronger. I always like to point out this difference here. So triamcinolone, 0.1%, so the same percentage. Ointment, cream, and lotion, you can see they're actually different strengths just because of the vehicle. So triamcinolone ointment is stronger than triamcinolone cream, which is stronger than triamcinolone lotion. So even if you just wanted to remember one steroid today, you can remember triamcinolone 0.1%, and you can just play with the vehicle in order to decrease and increase the strength. This is the Target $4 prescription list, effective as of a few months ago. I haven't looked at it in the past week or two. Sometimes things change, but you can see you have your triamcinolone 0.1% ointment and cream here, and you can get a nice big 45-gram tube. That's not enough for somebody with a lot of eczema, but it's not too bad. If you need something mild, you have your hydrocortisone 2.5% cream, and this one you can get 90 grams for $10. And then fluocinolone, which is one of the stronger options, you can get it in a cream form at Target as well. Of course, I still talk to patients about the potential risks of steroids if we overuse it, atrophy of the skin, stretch marks, HPA axis suppression, which is much more likely to happen in children compared to adults. But this will not happen with proper use. It will not happen if you apply it twice a day for 2 weeks at a time. And if you restrict the high potency steroids for a short period and use your lower potency steroids if you need longer maintenance. Keep using lower potency steroids for the face and body folds. You're not going to get into trouble there. And then just give limited refills and tell the patient why, how we use steroids and why we don't want to overuse it. So, sometimes I'll have patients bring the tube back in with them so I can kind of get a sense of really how much they're using. But overall, I think if we educate our patients in general, they're pretty responsible about this. And if you find that a patient is overusing steroids or they're calling you for refills pretty often, it means that their eczema is not controlled. It means that they need something else. They need systemic therapy. if they're calling you for a refill of steroids every month. Steroid phobia is real right now. I mean, on social media, there's a lot of stuff about topical steroids. So we're increasingly having these conversations with patients and parents of patients who are just really hesitant to use topical steroids. And, there's a relatively new phenomenon called topical steroid withdrawal syndrome, or TSW. And there are people with TSW who have big followings on social media. And so, I think this is basically tachyphylaxis, where if you overuse topical steroids, you're going to continue to need more and more and more in order to get the efficacy. Plus, when you stop the topical steroid, your disease is going to rebound. So I think this isn't something new. This is something we know that can happen with topical steroids, but it has a name and it has a following, and it's scary to patients, and they don't want to use topical steroids. I don't fight people if they don't want to use topical steroids. We can try the topical calcineurin inhibitors. We could try to see if we get crisaborole covered. Or maybe I'll just go to systemic therapy, because I can't undo the education that they're getting online, because what they get online, they believe more than me anyway. So it's a real conundrum sometimes. However, especially when I'm talking to a parent about their child with atopic dermatitis, and let's say we tried a topical calcineurin inhibitor and it didn't do the trick, I start talking to them about the risks of untreated atopic dermatitis. So I'm trying to not undo the topical steroid phobia, but really appeal to the idea that they want their child to get better. And if we don't control their itching, it's going to disrupt their sleep. It's going to affect their schooling. They can get skin infections from scratching. They can get thickening and, in some ways, disfiguration with like the changes in the pigment on the skin. So I really try to explain that we've got to get a handle on the eczema and build relationship, hoping that they'll trust me enough to do steroids for a couple of weeks if that's all we need to do. And that just is a good segue to just remind us that atopic dermatitis is more than skin deep. It's associated with depression, anxiety, conduct disorders, ADHD, autism. And the strength of that association does increase with the severity, and it may be because of the sleep disturbance that's associated with the disease, which leads to worse behavioral symptoms. So this is nothing to sneeze at. Plus, we know now, we believe that if we treat atopic dermatitis, we might decrease the risk of this child developing asthma. And that is a big deal. So how do we treat the itch? We talked about the fact that as long as they're itchy, the eczema will continue. You have to address this, and it really impacts patients' lives. You can try antihistamines, although the itch in eczema is not histamine mediated. So antihistamines don't work that well, but what they do is they put people to sleep. And so at least they'll get some sleep, and hopefully they won't be scratching all night long. So you can use Benadryl, or you could use hydroxyzine, anywhere from 10 milligrams a night to 50 milligrams per night. That can make people really, really sleepy, even into the next morning. So I would start low, see how they tolerate it, and then move up. Another option that I didn't put here is doxepin, which, if these two don't work, sometimes I'll move to doxepin in adults, and that can be helpful. At least it puts them to sleep. Of course, with antihistamines, you got to be careful with elderly patients, and sometimes they'll have a paradoxical effect in children, and the children will be all crazy and can't sleep overnight. So, got to warn people about that. This is my go-to, melatonin, 3 milligrams a couple hours before bedtime. Yes, it helps with sleep, but for unclear reasons to me, I'm sure there's some literature out there, it helps with itch as well. So this is what I tend to go with. And it's probably a little easier to convince some people to try melatonin. They feel like it's more of a natural option, and it can work really, really well. And then the other thing with itch is, if a patient has had eczema for a long time, and the itching is kind of part of their life. It's something that they just do. Even when they're not itchy, sometimes they're just bored and they scratch their skin. It becomes this habit almost. So we talk about that. We talk about behavioral suggestions like a fidget spinner. So they have something to do with their hands. I tell patients that the nerve endings in their skin, the same nerve endings carry itch as carry temperature. So if they use an ice pack, they literally cannot be itchy. So it's like a little bit of a hack. And it's one of the reasons people seek out really hot water when they're itchy. It helps because they're feeling the heat and not the itch anymore. So any behavioral therapy that you could think of would help. So what would we do with this patient? So we, of course, do our eczema skin care. She's someone I would give triamcinolone 0.1% ointment in a nice big jar, and we'll do the soak and smear where she gets out of the shower or the bath, and then we smear her with the triamcinolone twice a day. And then I would follow this child up very quickly. So I'll bring her back in 2 weeks just to make sure we're heading in the right direction. I'll recommend bleach baths. We'll start melatonin. And then in that 2 week period, if she's getting better, I'll send them home with maybe a topical calcineurin inhibitor, see how she does. But if she's not getting better, then we're going straight to systemic therapy with dupilumab, which would be my first choice, followed by an oral JAK inhibitor. We'll talk about dupilumab shortly. This is our third case. This is a 45-year-old woman with basically hand eczema. She's a kindergarten teacher, so she's washing her hands all the time, which is the biggest risk factor for severe hand eczema. And she's a caterer on weekends, so she's coming in contact with foods and again, also washing her hands a lot. And she doesn't wear gloves when she does like her housework and so on at home. So just some more photos of hand eczema. You can see this tapioca pearl-like lesion here. This is called dihydrotic eczema, just another term for hand eczema. So treatment for this patient is trying to avoid harsh soaps, same concept as the body, but it's actually more difficult with the hands. Depending on where you work, you're using these industrial strength soaps on the wall in hospitals, etc., and that really strips the barrier. So I tell patients to walk around with their nice little eczema soap. They should use gloves to protect their hands from contact with water and soap when they're washing dishes and doing other housework. And then, believe it or not, hand sanitizer, which is alcohol-based, you would think it would be more drying and more irritating for patients. Sometimes hand sanitizer is actually less irritating than soap, especially the better hand sanitizers, the ones that have lotion in them. And so I'll tell patients to alternate hand sanitizer and soap so that maybe they're washing their hands less, if possible. And then every time they wash their hands, they have to apply some kind of thick cream or ointment to try to, stop that transepidermal water loss. And in people with hand eczema, I go straight for the strong stuff, clobetasol ointment. And you can apply it more than twice a day in this case. You can imagine how hard it is to keep an ointment on your hands, right? You're washing your hands, you're going about your day, you're driving, and it's just kind of rubbing off. So they can apply it 3 times a day, 4 times a day if they like. Sometimes they can put gloves on. It could be the cotton gloves or it could be nitrile gloves. And then that'll help occlude the clobetasol and really help it to soak in and work a little bit better. And if they have these painful splits, these fissures in the fingertips, which tends to happen in hand eczema, you can just use crazy glue. That's the same, that's surgical glue, just, not sterilized. But it works really well. And it just gives the fissure some time to heal and it decreases the pain. And in somebody with hand eczema, like the patient in this fourth case, I would actually think pretty quickly about systemic treatment because one, it's her job, that's